you. Good evening, ladies and gentlemen. Welcome to Secrets of Neurology, Knowledge Feast for all neurologists. Episode 25th. We proudly present the team of John's Medical College. A very warm welcome to our program director, Professor Dr. Sudhir Shah, and Professor Dr. Lakshmi Narasimhan sir. We intend to close this meeting by 9:50. It would be an academic feast day. An honor for me, very briefly, our program has been running the longest academic web series, not only just for neurology, but for various. Dr. Sudhir Shah, Head of the Department, NHL MMC, SVP, MSR Ahmedabad, and there's also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. Author, conferred with most prestigious Padma Shri because of his contribution to society at large, recipient of the B.C. Roy Award, and recipient of Fiona Award. Our second program director, Professor Narasimhan sir, Director and Professor, Institute of Neurology, recipient of various awards and affiliations, Pal Tusiki Advisor, A.B. Baker, Best Paper Award, 3 times Institute member in Academy of Neurology, and successfully organized 7 consecutive clinical neuroscience program for all dear students. All the faculties, those who are logging in large number today, may I request both our program directors to take it forward from here.
Thank you. Thank you very much, Dr. Manoj, for this nice introduction. And I welcome you all on behalf of Dr. Lakshmi Narasimhan, my program course director, and also on behalf of INTAS Global Cell Division. I must thank and appreciate the audience for their continued support over all this 24 episode, and now today we have 25th episode of Learning Feast of Neurology, Secrets of Neurology. I think this is one of the most successful and long-lasting webinar series based on clinical pulse, case presentations, and lots of discussion. It gives tremendous material, particularly for the DN students and DNB students. But apart from that, according to our feedback, the practicing junior neurologists and many of our senior colleagues have also appreciated this wonderful program. We as course directors are very satisfied and happy and that the program is running very well. I must thank Global Cell Division of INTAS led by Mr. Chadda and his team, particularly Dr. Manoj and Dr. Haley and others for doing this wonderful service. Nice network. Without much ado, I will like to introduce today's team. Today, the presentation is from St. John's Medical College, Bangalore. And the DM resident who is going to present the case is Dr. Sucharita. Next one. Dr. Akshata is a junior consultant neurology at St. John's Medical College, Bangalore, and I'm sure she will dissect the case with a lot of information regarding the localization or differential diagnosis. This will be followed by Professor Raghunandan Nadi, senior consultant neurology, who will give important differential diagnosis and approach of the case as usually we have. And not the least, the most important part, the pulse of the knowledge, pulse of secrets of neurological pulse, would be provided by my very personal friend, Dr. Thomas Matthew, the professor and head department of neurology at St. John's Medical College Hospital. It would not be fair of me not to give proper introduction of my very close friend, Dr. Thomas, for his profound contribution to neurology and certain uncharted parts of neurology. He has literally brought out a lot of pulse in his practice and during his professorial work. As we know, he is one of the most outgoing student from his MBBS days, and he has received several awards like Satyadas Memorial Prize for first in medicine, first rank holder in MD from JIPMER Pondicherry, same way first rank holder from DM Neurology Nimans, and then Silver Jubilee Award Nimans. He was ex-honorary secretary for Bangalore Neurological Society and founder member and secretary for Forum of Neurologists of Multiple Sclerosis. He has started a stroke unit in St. John Medical College. Then he started stroke clinic, neuroimmunology clinic, headache clinic, amongst others. And he is the one who implemented the concept of MSc nurses for the disease like headache and all those. So this very useful and smart movement that helps in patient care. He has been invited to speak on TISABRI Indian experience at South Korea. He has for the first time brought out the side effect of clobazam as induced clobazam-induced pedal edema, and he has reported that. And it is also a very well-known thing that he has brought out aroma-induced seizure disorders, particularly eucalyptus oil and others. And he's very fond of talking of all those things. I'm sure today also during the three cases that the institute is presenting, there will be some flavor of aroma somewhere. I think there are three different cases, and it's called triology case. One is a deltoid weakness case, the second is spastic paraparesis, and third is a cluster headache. I'm sure all of us will enjoy this triology of neurology, and they will definitely be enlightened with some new facts. Before I hand over my mic to Professor Thomas Matthew, I once again very sincerely thank my colleague, co-course director, very learned personality, Dr. Lakshmi Narasimhan, for his wonderful efforts in making this attempt very successful all this time. You know, he's a very humble and kind man, but he has done tremendous work in neurology and done a lot of training for the DM neurology residents. With that, I once again thank the audience and students particularly, and request the St. John's Medical College to take over from here. Thank you very much.
Thank you, Professor Sudhir Shah, for that wonderful introduction. And we are very grateful to you for inviting us to share our cases today, also Dr. Lakshmi Narasimhan and the Indus group. So we have three presentations there, and we'll start with the first, which is a detailed presentation. Second will be a very short case to highlight a simple point. And third will be a case of cluster headache, where I'll be highlighting certain few concepts in the etiology of cluster headache. So I think our DM resident, Dr. Sucharita, will start presenting the case. So we'll start with the first case because we don't have much time at hand. So I will ask Sucharita to share her slide and start the first presentation.
Sure, sir. Good evening, everyone. I'm Dr. Sucharita, neurology resident from St. John's Medical College. Today, I'll be presenting an interesting case of right arm weakness. He's a 39-year-old male patient, agriculturist by profession, who presented with weakness of the right upper limb since 5 days. He noticed this weakness since 5 days, incidentally, when he was trying to fix a bulb, which was non-progressive in nature. After that, he is unable to perform overhead abduction activities like opening the bolt. There's no history of difficulty in performing buttoning or unbuttoning, mixing food, or gripping objects in the same hand, suggestive of distal limb weakness. There's no history of pain before or after the onset of weakness. No complaints of thinning, tingling, or numbness. No history of neck pain, restriction of neck movements, radiating pain, or pain on coughing. No complaints of weakness of any other limbs. No history of diplopia, ptosis, or difficulty in swallowing, suggestive of bulbar symptoms. No history of fluctuating weakness or fatigable weakness was obtained. No history of transient neurological symptoms in the past, with no bowel and bladder incontinence and no walking difficulty. Coming to the personal and the past history, he is not a known case of any pre-morbid conditions like diabetes, hypertension, or thyroid disorder, with no addictive habits like alcohol or smoking. He consumes mixed diet, appetite was good, and with regular bowel and bladder movements. No significant family history was obtained. Summarizing the history in short, he's a middle-aged farmer with no known comorbidities who presented with painless static right arm weakness for 5 days. Dr. Akshata will now take over and talk about the differentials regarding the history, after the history.
Good evening, everybody. So coming to the differentials after the history. So here we have a middle-aged man who has presented with only right upper limb weakness, which has been static, and he has incidentally noticed the same. So coming to the probable causes of it. So firstly,
Sucharita, you're muted. You're muted. Sucharita, you're muted. And show the video towards Akshata's face. I think Akshata is not seen.
Okay.
Start again. We didn't hear you.
I am okay. So coming to the differences. Hello.
I think two laptops are there. One you mute and you speak from one.
It's a problem. One must have joined through mobile, so they have closed the mobile.
I think they are sharing from one laptop, so that is the
Yeah.
issue. Okay.
Hello?
That may be the reason.
Now it is clear.
Yeah,
sir?
now it's okay.
Now it is
Now it's
clear. Yeah.
Okay. So coming to the differentials after history, here we have a middle-aged man who has presented with mostly acute history of right upper arm weakness with no, which has remained static since then. So it could be a CVA, which the patient might not have noticed the acute presentation. So we are thinking of a CVA or a cerebral cause because it was probably acute onset and it is painless and it has remained static. The odd points is normally whenever we talk of a CVA or a cortical lesion, usually typically we say that they have more distal weakness compared to proximal. And in this patient, we have only the right upper limb, the focal weakness without any limb involvement, any face involvement, etc. And he doesn't have any risk factors for the same. So still, if we think of a CVA, the probable lesion would be in the precentral gyrus in this area, which localizes for the arm in the homunculus. So probably there might be a small watershed infarct in this area, or sometimes very rarely arteriofubular, or which is also called as medial lenticular artery, causing infarcts of the anterior limb of internal capsule can cause this weakness, but usually it is dense involving the face and the arm. So here there are some reports where this is noticed that isolated shoulder weakness can happen after a small cortical infarction, and there these patients had statistical infarct in this precentral gyrus, which is localizing to the area of the arm. So in this area they had these statistical infarcts. So in one of these patients, patient had stenosis, and patient developed a small artery to artery emboli, or because of small hypotension, patient can develop these small infarcts, which can rarely present as isolated shoulder weakness, even because of the CBM. But it is not the ideal case in a CBM. So coming to the next possibility, because this patient has minimal symptoms, it can be a presentation of many diseases. So similarly, radiculopathies also can present with upper arm weakness. That is only the shoulder weakness in case of C5-C6 radiculopathy. But in this patient, the odd points was there was no neck pain, there was no radiating pain, there was no history suggestive that he lifted any heavy weights before the onset. There are no sensory symptoms. There was no history of pain or coughing. But sometimes even radiculopathies can present without pain, especially when it is a central disc herniation and when the sinovertebral nerve, which is a sensory supply, may not be involved. So in such cases, very rarely we may get the radiculopathy without the pain. So coming to the next localization, which could be a brachial plexopathy. So again, brachial plexopathy, in that also the C5-C6 root or the upper trunk, if it is involved, then we can have a proximal weakness in the upper limb. So whenever, briefly seeing the brachial plexus is formed by C5, C6, C7, C8, T1 nerve roots. In that, the C5, C6 roots will form the upper trunk. So again, upper trunk divides into anterior division and the posterior division. The anterior division of the upper and the middle trunk will form the lateral cord, so which supplies the pectoral muscle, biceps, and medial root of the median. From the upper trunk, we also have the suprascapular nerve, which supplies the supraspinatus and the infraspinatus muscles. From the C5-C6 root, there is also a posterior division which contributes to the posterior cord. And that C5-C6 root of this posterior cord supplies the axillary nerve, which supplies the deltoid, which is the predominant weakness in this patient because he was not able to abduct or do overhead activities. And it also supplies radial distribution. From radial, it supplies mainly extensor carpi radialis. In median, the C5-C6 root will mainly supply the pronator teres muscle. So if we have a complete C5-C6 root or the upper trunk injury, all these muscles can get involved, or there can be a partial involvement of these, and some of these nerves can get involved. And another etiology where there can be brachial plexus is the neuralgic amyotrophy or the Parsonage-Turner syndrome, where the individual, some of the nerves can get involved. So typically, the neuralgic amyotrophy will start with pain. Patient will have severe pain over the shoulder, which lasts for over a week. Then after that, the pain subsides, after which the patient develops weakness. Then usually the weakness will progress, and after that there can be atrophy also. So typically the most commonly involved nerves in this neuralgic amyotrophy are suprascapular nerve, anterior interosseous nerve, and the long thoracic nerve. So, but in this patient, the odd points are that there was no pain at the beginning or even after the onset. And sometimes the upper trunk of the brachial plexus can get involved whenever there is any stretch injury or a traction injury to the upper limb, during which the upper trunk can get damaged. So, but that history also is not available. And there was no sensory symptoms because these C5-C6 roots will supply both sensory and motor. So coming to the next differential, that is a neuromuscular junction. So in neuromuscular junction, the points for was it was a proximal weakness and it is painless, and mostly it started acutely and there was no sensory. But here the patient had mainly unilateral weakness, which is not usually a feature of myasthenia. Usually in neuromuscular junction, we have symmetric bilateral weakness. Along with that, patient will have typically fluctuations They can have diurnal fluctuations, or sometimes even they can say some days they are better, some days they are worse. Or patients will usually present of fatigability, and especially because this patient had upper limb weakness, patient may tell that while they are bathing, initially they can bath, but later the hand becomes fatigued and they can't continue bathing. And in case of ladies, they can complain that they may not be able to comb their hair or tie their hair because the limb gets fatigued when they continuously try to do the overhead activities. But in this patient, we did not get any such history for the upper limb for fatigability or fluctuation. And one more thing was, it was unilateral presentation, so it was kept a little lower down in the differentials. So next, coming to the muscle, again, because it was a proximal, acute, and history-wise pure motor, muscle is also a thing which should be kept in the differential. If we think of muscle involvement, it could be focal myositis. But whenever we have focal myositis, typically the patient will complain of pain. There might be some swelling over the affected area. And usually a myositis happens after any injury to that site, or sometimes any infect bite, or sometimes even it can present as a systemic feature of a immunological disease. Like it is called pseudotumor, where recurrently there is focal myositis. So, but in this patient, again, there was no pain, no swelling over that affected area. So it may be unlikely, but still it is kept in a DD because they can still present with upper limb weakness. So coming to the next differential, which could be anterior Honsel. Again, for anterior Honsel, patient has incidentally noticed and it is painless. There are no sensory symptoms. So we cannot deny that it may be an early onset of a anterior Honsel disease. And in anterior Honsel disease, it could be early onset ALS. Still, however, this patient has not developed any wasting. There are no fasciculations, and still it is a short history for us to make a diagnosis of anterior Honsel disease. Sometimes this is not a typical age group for monomelic amyotrophy. Usually around 10 to 30 years age group, in that age, monomelic amyotrophy presents, usually which is known as Hirayama disease. Most of the time in Hirayama disease, the C8T1 roots are typically involved, but very rarely even C5, C6 roots also can get involved in proximal monomelic amyotrophy. But in this age, it is a little less likely, and in him the presentation is only 5 days, so it is unlikely cause. Just for the discussion, this is kept here. So, anybody else, any other differentials or anything?
Oh, Sucharita, continue. Sucharita, continue. Examination, you continue.
Coming to the examination, he's a middle-aged male, moderately built and nourished, conscious, oriented to time, place, and person. Vital signs were stable. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema was noted. No erythematous rash or local rise of temperature over the arm was noted. Higher mental functions was normal. Cranial nerves were normal. On motor system examination, no wasting or fasciculations were noted. Tone was normal. Power in the right shoulder, that is abduction above 30 degree, was affected. It was just 3/5. Whereas adduction, flexion, extension was all 5/5. The power in all the other muscles were 5/5. Deep tendon reflexes were elicitable and it was 2+ in all the limbs. Superficial reflexes were present and plantar was flexor. Coming to the sensory examination, pain, touch, both fine and crude touch, and temperature was normal. Joint position sense and vibration was normal. The area supplied by the axillary nerve, the regiment patch area, that was also normal. Coordination, the finger nose test and the heel chin test was normal. Gait, waddling gait was not there. It was absent. Gait was normal. No neck stiffness or no meningeal signs. Skull and spine was normal. Fatigability test was, he was up to 30 degree. He was able to abduct his arm, and in that, when we did repeated stuff, when he was able to hold it for around 45 seconds. But in the other arm, he was able to hold it for up to 2 minutes. So it was taken as plus or minus. Other systemic examination was normal of the other systems. At the end of the examination, the deficits were isolated right deltoid weakness with preserved reflexes. The differentials that we considered at this point of time and the structures involved were nerve and neuromuscular junctions. The possibilities were axillary nerve injury and the other one was myasthenia.
So now after examination, we saw that the patient after examination had only isolated deltoid weakness, which is very odd for a CVA or for a radical or for a plexus. So isolated deltoid is more common in axillary nerve injury. So axillary nerve injury usually happens whenever there is any traction injury to the shoulder or whenever there is shoulder dislocation or there can be a closed blunt trauma. So whenever axillary nerve is involved, there may be deltoid weakness. Along with that, teres minor weakness also may be there. Along with that, they will have sensory loss over the area which was shown. But because axillary nerve supplies only a small area and there is overlap by the other nerves, sometimes the sensory examination may be normal. So because sensory examination was normal, we can't negate that axillary nerve injury might not be there. So coming to the next differential which was kept, that is myasthenia. Coming to the myasthenia types, so typically whatever most common type of myasthenia is acetylcholine receptor antibody related myasthenia. In this, patients present either with ocular symptoms or with bulbar symptoms or with a proximal upper limb or the lower limb weakness. Proximal upper limb weakness is more common. Then the other type is musk myasthenia, which contributes to 4%. In that, usually they present more with bulbar and the proximal limb weakness, which is comparatively severe form of myasthenia. Whereas the LRP4 myasthenia is usually a milder disease compared to ACHR and the musk myasthenia. Similarly, the seronegative myasthenia gravis is also comparatively a less severe disease. The LEMS is not a type of myasthenia. It is a presynaptic disorder where they present mainly with a limb girdle type of presentation. But however, there may be unusual presentations of myasthenia where they can present only with limb girdle myasthenia, or there can be isolated distal weakness in the upper limbs. There can be post-exertional axial weakness with dropped head, like neck drop they can present with only neck drop. When they sit constantly, the neck drops, or they may have isolated jaw drop also. Or they can have facial isolated unilateral facial weakness with ptosis. We can have sudden hypoesthesia with recurrent falls. Also, vocal cord paralysis has also been described as a presentation of myasthenia. And in myasthenia, typically neck flexors are more involved compared to neck extensors. And deltoid, triceps, extensors of the wrist and fingers are usually more weaker compared to other muscles. And isolated weakness of one or more extensors of the fingers has also been described, where patient may have only finger drop in the beginning. When we do the fatigability test, they may not have the whole arm which droops, but only the finger drooping might be seen. So these two were thought as the differentials.
Coming to the investigations, the routine blood investigations were normal. Vitamin D was slightly on the lower side. Apart from that, TSH, CPK, serum potassium, serum calcium, and phosphorus was normal. MRI brain was also done, which was normal. MRI spine did not reveal any cord compression or any intravertebral disc prolapse. ENMG was normal. The axillary nerve conduction study was also normal. The clinching investigation was repeated nerve stimulation, which showed a significant decremental response of 25%. After the RNS, history was retaken and reassessed. On probing, he said that he had jaw discomfort on chewing hard substances. However, there was no difficulty in swallowing, no history of nasal regurgitation, or no history of fatigability. After this, we went ahead with CT thorax, which revealed a lesion in the anterior mediastinum, which measured 6.3 into 3.4 into 3.4, which was suggestive of a thymoma. The next investigations we sent was acetylcholine receptor antibody, which turned out to be negative. The final diagnosis was acetylcholine receptor negative thymomatous myasthenia gravis, MGFA class 2A.
Sir, shall I continue? Or,
Yeah, before,
Raghu, let them finish and then we'll continue. Let them finish. Go ahead, Akshata.
Yes, sir. So MGFA classification is Myasthenia Gravis Foundation of America. According to this, myasthenia is classified into 5 classes. Class 1 is only ocular weakness. Class 2 is mild weakness. 3 is moderate weakness. 4 is severe weakness. And in all 3, it is divided into again A and D, where A is predominantly affecting limb and axial muscles with less involvement of the bulbar, whereas B is predominantly involving the bulbar with less involvement of the limb muscles. Whereas 5 is defined by intubation with or without mechanical ventilation. So coming to the course, in this patient, RNS showed decremental response, which was suggestive of a NMJ disorder, whereas his acetylcholine receptor antibody came negative with the thymoma. The typical teaching is that whenever there is a thymoma, the acetylcholine receptor antibody is 100% positive. But it was not a case in this patient. In this patient, because there was suspicion of NMJ disorder, both CT thorax and acetylcholine receptor were sent simultaneously. And CT thorax, however, we could do it earlier. The report we could get earlier. The right proximal weakness improved with pyridostigmine, and patient was because patient was in a stable condition. There was no bulbar weakness. He was not in any impending crisis, and he was stable. Patient was referred for thymectomy, and he underwent thymectomy. Post that, patient had mild hoarseness of the voice and mild worsening of the weakness, which is expected post thymectomy. Because of the thymic storm, there will be release of antibodies post the surgery, because of which worsening is expected. That's why we were prepared for it, and IVIG was kept ready, and patient was given IVIG, that is half dose of IVIG was given for 2 days, and he improved in his weakness and even the voice improved. Then patient was kept under observation for 4 to 5 days and he was discharged. Because he had hoarseness of voice, he was evaluated and there was left vocal cord palsy, which was thought which could be related to the compression of the tracheal tube, or it could be a part of the myasthenia causing vocal cord weakness, which is being described earlier. So shall we go to the next case?
Yeah, Raghu, you want to add?
Yeah. So basically, in this case, if you notice, few things were there. Patient had a, incidentally, we don't know whether it is an acute or not. He noticed one fine day that he does not have, he cannot lift the arm, and that was a pure motor syndrome. So since you usually as an acute nature, all we think as of a CVA, then it could be a small plaque demyelination, or since no neck pain and all, we end up doing investigation of like a scan of brain and spine. So most of the times in this patient, it has come normal. So in any patient with proximal muscle weakness alone, the localization is the most thing. If we had examined the patient only the deltoid weakness, then we should always think of an axillary nerve involvement. But in a clinical practice, we end up doing these investigations, and even though it is normal. So then the next thing we did a nerve conduction. Nerve conduction also is showing normal. So next we have to do an EMG, which was, it was not showing any, it was a normal EMG there, but interference pattern will be abnormal if there is in a neuromuscular junction abnormality. When we do a EMG, sometimes you can get a low CMAP, or it can be normal. Sometimes you may do exercise, especially in a presynaptic, you can get a increased CMAP after the exercises. So it is always better we have to do an EMG. So EMG would have picked up here if it is a pure like a neuropathy, like an axillary or a pure anterior horn cell C5. So EMG was, which was not done here, but basically EMG may show in a neuromuscular some impaired interference. Then once we did an RNS in this usually a weak muscle, deltoid in here, trapezius, which was done, which was showed abnormal. So, but most of the time, sometimes even RNS can be coming as normal in a neuromuscular junction. The sensitivity varies from 50 to 70% a routine repeated nerve stimulation study. I'm not talking about single fiber EMG. So clinically, it's an important thing what we should consider everything. And then when we do antibodies also, AChR antibodies can Some in a generalized myasthenia, up to 85% it can be positive. But as Akshata was telling, if you have a thymoma, it can be 100% positive. But sometimes you may not get anticholinesterase receptor antibody being positive, because the type, how we check it is important. Whether it is a radioimmune assay or it is a cell-based assay. Cell-based assay are more sensitive in picking up the antibody. So one should always go back and check the patient, check what method has been used. And the second important thing, in early myasthenia, AChR can be negative, but one may have, if a strong clinical suspicion, one may have to repeat the antibodies after a few months. You may find anticholinesterase receptors being positive. At the same time, here the surprising thing is, when we see a clinically patient RNSP is positive, we do a CT and we send the investigation for AChR. So turnaround time depends on the labs. Sometimes you may get in 48 hours, sometimes it may take a week also. So in that time, the decision is most important, how to manage these patients. So if in a given patient clinical suspicion, and we can give a therapeutic trial or even give a neoadjuvant test, which we have not done this test, with pyridoxine tablets only he improved. Otherwise, the next step in most of these patients is doing we don't do a heterophonia neostigmine test to see whether there is an important improvement. We can get this diagnosis within few hours. If you suspect, if there is no contraindication to do a neostigmine test, like they don't have asthma or any cardiac abnormalities, one can pick it up very early. So most of the time we also see this is one of the mimics. Sometimes we have seen patients who can come with only slurring of speech, intermittent slurring, being diagnosed as TIA, and only the bulbar weakness. So it is the most important thing in the history. Later in the evening or repeatedly speaking, they'll get dysarthria. Sometimes RNS can be negative. One should always have a clinical suspicion of, in a pure motor syndrome, neuromuscular junction abnormality. So that is how we work up a case and then pick up based on the clinical scenario as a history and then the examination.
May I ask a couple of questions?
Yes, sir. Yes, sir.
It's a very interesting case, and it really is exciting, and it provokes so many questions. As for example, if you had not thought of doing RNS, I mean, how would you have settled the diagnosis? Suppose the RNS was negative, what would you have done?
So that is
I answer that question because I am the one who have admitted the patient. So in the OPD, when this man came, he just told, I'm not able to lift the hand. Then I checked, it was an isolated deltoid weakness. So I was thinking, how could it be? Initially, I was thinking of a radiculopathy with no neck pain, biceps is absolutely strong. And how an isolated deltoid muscle weakness can come. That time he told something with respect to the jaw. He told, I have some pain in the jaw here. So we thought it's not significant. And then we admitted the patient, and then because thought, though there is no pain, people's reflex was to just do a scan and see any disc bulge, but there was no disc bulge. So in the rounds, I was talking to him again, and then we clarified the history. Then he was telling that, he gets some pain while chewing the food. Then I told, when you do the proximal nerve conduction, please do an RNS test also, and surprisingly it came positive. When the RNS came positive, and it was a very, significant decremental response. And then what we told, okay, go ahead with the CT chest, and we sent the acetylcholine receptor antibody. CT chest was done, I think, the same day. And we saw the thymic tumor. And then we were very happy that a diagnosis was kept. And it was very intriguing, and to know that an isolated deltoid muscle weakness with no ocular muscle weakness in a myasthenia. But anyway, thymus tumor was there, so we are happy. And then we didn't bother about acetylcholine receptor antibody because it will take some 3-4 days. And because of the thymoma is there, we asked them to go ahead with the surgery, and he was only a mild weakness, lung functions and other things were normal. And we were ready with the IVIG if any weakness. And surprisingly, acetylcholine receptor antibody, it became negative. And usually it is, in our practice, I've rarely seen any myasthenia with negative. We see false positive acetylcholine receptor antibody in other patients, but to have a patient with a neuromuscular weakness and then with a thymoma to get an acetylcholine receptor negative was very surprising. Then we didn't go with other Titin and Rhinodine and other antibodies because anyway, patient was already operated and he was improving. So we didn't want his money was a problem. So we didn't do with other investigations. And but cases teaches that this myasthenia can be a very big surprise in clinical practice. We ourselves have patients with diabetes have come with mimicking Turner palsy. We are given short course of steroid, they improved, and then after some 1 month they will come with other eye weakness. Then we realized that we have missed a myasthenia. And indeed, Dr. Raghu was sharing today morning, one of his relatives, close relatives, had slurring of speech. People thought TIA, and then it was myasthenia. So myasthenia can be a great mimicker. So that is the main presentation on today, that when you have a painless, isolated muscle weakness, though it may be asymmetric, don't forget about myasthenia. And anything with respect to cranial nerves, you should probe. So initially we thought what is telling the JOAS may not be significant, but it became the main clue that it may be a myasthenia. So listen to patients and don't try to fit into your usual diagnosis of radiculopathy when you don't have the key findings. So it was an eye-opening case, and myasthenia can present in any of the ways. So that was what, that's what we were trying to present.
Matthew.
Actually,
Lakshmi, go ahead. No problem.
Now, isolated triceps weakness until proved otherwise is myasthenia.
Absolutely.
There are a lot of case reports are there.
Yes.
I was surprised. I would because that's the time when I learned we had a similar case with isolated triceps weakness. When we looked into the literature, we came to realize that isolated triceps weakness in the absence is almost always until proved otherwise is myasthenia. So many case reports are there. So that means there is something, this is also worth publishing, because I realized that this isolated muscle weakness can be a form of presentation of myasthenia without any ocular or any other presentation. So thanks for a wonderful case, Matthew.
So my point was also same, because I had also come across this isolated tricep weakness ultimately being proved as myasthenia. So we have made a protocol that whenever we do electromuscular testing for any muscular weakness patient, we usually add up RNS, repetitive nerve stimulation, because right from limb girdle myopathy type of presentations to isolated weakness of muscle, and as you know, this can be missed if we have not. So RNS should be a usual accompaniment of all neuromuscular studies. That's my point. And secondly, Thomas, I wanted to ask you, I mean, how many muscles were studied during RNS?
What usually our protocol is, we take one orbicularis oculi, then trapezius, and then the abductor digiti minimi. These are the three muscles we routinely do. And because he has the weakness, the deltoid and trapezius was focused in this case, and it became positive.
All right, fair enough. So other muscles were negative here?
Yeah, other muscles were negative. Distal muscles were negative. Trapezius and deltoid both showed decremental.
Sure. Okay, fine. Thank you very much.
Then, as we were discussing, this case was full of surprises, because his onset was somewhat acute. Then people in this history was confused whether he noticed or it was there. So acute presentation was a surprise. Isolated deltoid weakness was a surprise. Then acetylcholine negative antibody was a surprise. And post surgery, all other muscles improved, but he had a vocal cord palsy. Then was a doubt whether, the post thymectomy, whether they have touched the recurrent laryngeal nerve, or it is an endotracheal tube complication, or it is a myasthenia. So then we just gave a small course of steroids, and then nothing happened. And 2 doses of IVIG also we had given. And with that, he improved fairly well. And then we observed for a few more days and he was discharged. So it was a challenging case and a lot of surprises. So that's what we thought to present this. And then I think we have plenty of time. So we'll go to the next case. It is also a very interesting case, because he just came with a spastic paraparesis, and Sujita will share the case. It is not that long case. So let us see that, also learn and point from that. So thanks Akshata for the wonderful discussion. You are the star of the presentation along with Sucharita, and you have done a wonderful discussion on differential diagnosis and localizations with the deltoid weakness starting from the muscle, neuromuscular junction, plexus, and the root and the anterior horn cell and going up to the cortex. So it was a wonderful presentation from both of you, and let us go to the next case.
Okay, the next case, going on to the next case, it's a case of spastic paraparesis. He's a 60-year-old male who is an agriculturist by occupation who presented with complaints of lower backache since 5 months and difficulty in walking since 4 months. Coming to the history of presenting illness, he presented with lower backache since 5 months, radiating to both. Sorry, sir?
Slideshow.
Hello? Can I continue?
Put the slideshow. Put the slideshow. I think
Slideshow,
that's
put the
just, I don't know.
slideshow.
Oh, okay.
Like that, or just put the slideshow.
Yes, sir. He had lower backache since 5 months, which was radiating to both the lower limbs up to the ankle, which was dragging in nature. Feeling of heaviness, log-like sensation was present, which used to worsen on with walking, not present at rest or on standing. It was associated with stiffness of both the lower limb. He also complains of weakness of both lower limbs that was symmetrical in onset and insidious and gradually progressive. It initially started with difficulty in getting up from squatting position and to climbing chairs. But he was ambulant, but he was able to walk by himself, but with some mild difficulty because of the stiffness. No history of slippage of footwear. History of urgency was present. No history of tingling, numbness, loss of sensation was present. No history of difficulty in guiding feet into footwear. No history suggestive of incoordination in the upper limb. No history of band-like sensation. No speech abnormality like dysarthria. No history of blurring of vision or double vision. No history of facial deviation or difficulty in swallowing. No history of weakness or sensory symptoms in the upper limbs were noted. No history suggestive of flexor spasms. No history of thinning of limbs. Coming to the past and the personal history, he had no premorbid conditions, was not an alcohol, no history of alcohol or smoking. He consumed mixed diet and appetite was good. Bladder, he had urgency, but apart from that, it was okay. And bowel was regular. On examination, he was moderately built, conscious, oriented to time, place, and person, and the vitals were stable. Cranial nerves were normal. Motor system examination did not reveal any fasciculation or wasting. The tone in the upper limb was normal. Lower limb, he had grade 2 spasticity according to modified Ashworth scale. Power in the upper limb was 5/5. In the lower limb, there were more of proximal weakness. Mostly in the hip, extension was mostly affected than flexion, abduction, and adduction. Ankle, it was 5/5. Toe grip was good. It was mostly proximal weakness what he had. Deep tendon reflexes were brisk in the upper limb as well as in the lower limb, but he had ankle clonus. Superficial reflexes were intact. Abdominal reflex was present. Sensory examination was normal. He had no cerebellar signs were present, no meningeal signs were present. He had a spastic gait. After history and examination, it was a case of spastic progressive paraparesis with brisk reflexes with bladder involvement with no sensory involvement. The differentials that were considered were non-compressive myelopathy, which were longitudinally extensive transverse myelitis, but the odd feature was there was no sensory level, vitamin B12 deficiency, but there was no posterior column involvement, HTLV1 infection, and copper deficiency, primary progressive multiple sclerosis, PLS, and ALS were considered. But there was no history of thinning, but there was no fasciculations for ALS. There were no wasting that was noted. Blood investigations that were done was CBC and peripheral smear, which were normal. TSH and vitamin B12 was normal. MRI brain was normal. MRI spine revealed C5, C6, mild IVDP and L4, L5 IVDP. ENMG was normal. Copper levels were done, which were normal. An MRI done outside was reported. This was the MRI picture that was done outside. It was reported as normal. We did a repeat MRI. This is the T2 sagittal and axial section of the MRI. Here we notice that there are multiple flow voids in the posterior subarachnoid space and subarachnoid space of the dorsal spine and prominent flow voids in the left lateral recess and anterior epidural region of L2 vertebral region. And we can also see that there is core hyperintensity in the dorsolumbar region, suggestive of cord congestion. This was a CIS-3D sequence that was done in our hospital, which shows the flow voids in a better resolution.
Sucharita,
Yes, sir.
yeah, what I think what we should go to the first scan, which was done outside.
Yes, sir.
This is a 3 Tesla. So this is a patient who came with a spastic paraparesis with an outside scan, which was looking apparently normal. And if you go very closely, there was a doubt that I think you can point the arrow there, Sucharita, there, down here, a little more down, little more down, little more down, yeah, there, little up there, yes. So there was a small doubtful void. But otherwise, you know, the scan was reported normal, everything was appearing normal on this scan. And then patient had a few months subacute spastic paraparesis progressing. So I think some intuition made me think that there may be something wrong. Let us check up. So we did a 3 Tesla MRI. And in the 3 Tesla MRI also, there was a doubt. And then we went for the CIS-3D sequence. So that cleans the diagnosis. So the important point is that even when you have a doubt in a spastic paraparesis, don't forget to do a CIS-3D sequence. So CIS-3D sequence is the best to pick up the arteriovenous malformation. So even a 3 Tesla also was a little doubtful initially, though it was showing. Then the CIS-3D clearly cleaned that there is a dural arteriovenous fistula. And even the first scan, there is no intrinsic changes in the cord. So it is just a beginning of a spinal dural arteriovenous fistula, which may come with a backache and worsening with exertion, and can come with either radiculopathy or a spastic paraparesis. So carefully search for this voids and always do a CIS-3D in your protocol when you work up for non-compressive myelopathy. So otherwise we would have missed this case. And then we did the embolization and he improved and we discharged him recently. So that was just to say that whenever there is a progressive spastic paraparesis and when you do a 1.5 Tesla scan, carefully see. And if you see very few voids, you go for a CIS-3D and maybe in a 3 Tesla so that you don't miss the diagnosis of a dural arteriovenous fistula causing a spastic paraparesis. And intrinsic early stages, you may not see intrinsic cord changes. So that was the case we wanted to tell and bring that point so that you don't miss a spinal dural arteriovenous fistula. I think, Sucharita, any other slides?
Another thing to add the point, sir, the history-wise, progression means exertional worsening of the spasticity.
Yes.
So that is one of the clues in the history where we have to, many patients with either like in MS and all, sometimes may worsen, but here in this patient was definitely giving, while walking, his spasticity worsens. He find more difficulty after walking sometimes. So that is a clue for it's like a claudication pain. How we get in the leg, it's the claudication of the venous edema of the cord. They can have the symptoms. So that part of the history, once we have that history, one should closely look for this AVMs. So that is one of the other pointers.
And one more interesting relationship with respect to the myasthenia case, and this is that you should not give steroids to spinal dural arteriovenous fistula cases. There is a chance that especially there is a spinal intrinsic changes. You may have a doubt, you mistake it with an LETM, then you may give steroids. These patients with dural arteriovenous fistula worsens for some reasons like venous hypertension and increase in fluid and the retention due to the steroids. There can be a worsening. Same with myasthenia also, you know that steroids at times can worsen. So same with the spinal arteriovenous fistula. The few conditions which worsens with steroids in neurology, one is the spinal dural arteriovenous fistula, then you have myasthenia, especially high dose steroids. You started myasthenia, it may push into crisis in around 30% of patients. And then you can also have a multifocal motor neuropathy with like a Lewis-Sumner syndrome. There also Lewis-Sumner syndrome, sometimes when there is a focal demyelination, that can also worsen with steroids. So these are a few conditions which worsen with steroids, and keep in mind. And one more point I wanted to tell in the previous case was when acetylcholine receptor antibody is negative, it can be either LRP4 or MuSK or anything else that. And sometimes in a true acetylcholine receptor antibody negative myasthenia, you may have to do a clustered acetylcholine receptor cell-based assay to pick up acetylcholine antibody in some cases. So there were studies where they did this type of clustered acetylcholine receptor, and they found that around 45.8% of seronegative myasthenia gravis had acetylcholine receptor antibodies. So that may be another reason the way you check the acetylcholine receptor, and a clustered assay is more specific for detecting in negative patients. That was one more point I wanted to tell. Okay, Sucharita will go to the next case.
Shall I?
Any questions, sir? Please, sir. Have any point to be asked or
Yeah.
question?
I mean, here in the second case, there are two usual fallacies that we come across. You see, there is the problem is under-reporting or over-reporting of spinal MRIs, and for some unknown reasons, spinal MRIs are more read incorrectly than brain MRIs, and for whatever reasons. The 1.5 Tesla and 3 Tesla business is also important. The eye of the reader is very important many times. When they report neurologists, if they are not trained or they are not particular, then they also just missed the whole diagnosis. And this diagnosis of spinal dural AV fistula is not very uncommon. We do see a good number of cases these days. And one should also remember that AV malformation spinal is different from dural AV fistula. Another point is in many centers we have seen and that limited cut. I don't know what is that limited cut business, but MRI brain limited cuts, MRI spine limited cuts. Now, I mean, there's a disservice to the society. When you ask for the limited cuts, you tend to lose and miss so many important diagnoses. Either you do it or you don't do it. And particularly situations like this with paraparesis, particularly the orthopedic friends, and I should not say so, but they have a tendency to write some in lumbar. For the spastic paraparesis, some of the other colleagues also write lumbar MRI, and they don't look at the higher dorsal or cervical MRI. So I think we should, as a neurologist, make it a point to have full MRI study, proper MRI study, and should be read particularly with the senior radiologists, go and discuss with them in the rounds. And if you have doubt, as Dr. Thomas said, this 6 studies and 3D studies are very important, and don't miss those flow words. If you see carefully, even in the axial also, we are able to find out. So I think the crux of the thing here is reading of MRI for the diagnosis of spinal dual AVF. I think it's a good case and a very nice learning point. Kindly go ahead with the third case.
Sucharita, start the third case.
Yes, sir.
Do you have the present here?
Yes, sir. Shall I start, sir?
Yes, please go ahead.
This is a case of unmasking the cause of headache. This is the history. This is a story of a 50-year-old male who was an agriculturist who presented with headache for 2 months. His headache history was like for past 2 months he's had headache, which was insidious in onset. The distribution was in the right periorbital, frontal, and temporal region, lasting for 30 to 60 minutes. Frequency being 4 to 5. The nature was it was throbbing in nature, associated with watering and redness of right eye with photophobia. No history of fever, ear pain, or ear discharge was noted. On examination, he was moderately built and nourished, conscious, oriented to time, place, and person. And fundus was normal. No temporal artery tenderness was noted. No focal neurological deficits were there. No neck stiffness was there. The investigations that we performed were MRI brain, which was normal, and ESR and C-reactive protein, which was normal. Differentials were trigeminal autonomic cephalalgia, that was cluster headache, was considered. What was the cause for this?
Sucharita, I'll take over.
Yes, sir.
So otherwise people won't believe you. So you can tell what happened. You can tell, and then I'll continue with the sides of that.
Okay, sir. History that was missed was history of use of Dabur Red toothpaste for 3 years and use of Vicks lozenges for 2 months.
So what did you do? You tell. You only manage the patient, so you can tell.
Yeah, so I'm not getting the slide once again. So the only treatment we gave for him was we asked the patient to stop using Vicks and the Dabur Red toothpaste, and he was given a headache diary. The headache diary was given so that the headache frequency was noted, and for how long the duration was there, that was noted, and the severity was noted. And to our surprise, within the next 70
Surprise, no surprise. We know it will happen. So go ahead. Show the diary.
Yes, sir. I'll just put up the headache diary thing. Sir.
Sure.
Yes, sir. So you
Yes, sir.
continue, sir. I'll put it up.
No, you show the diary, then I'll start.
Okay.
So it was a surprise for you. I had no surprise. So just go ahead and then we will go for the presentation. The diary is with you.
Yes, sir. Yes, sir. It's there.
Just put it up. Yeah. Just explain the diary.
Yes, sir. He was admitted on 16th. On 16th, he had 5 episodes that lasted. Most of the episodes lasted for around 40 minutes. And the intensity, as we see, is above 7, 8, 7, 8. On an average, 7 to 8. On 17th, the next day, he had 3 episodes. The duration came down from 40 minutes to 20 minutes to 15 to 20 minutes. And the intensity here decreased to 4 to 6, on an average 6. The next day, he had just 1 episode that lasted for 10 minutes and the intensity was just 1 to 2. And the next day also, after that day, he had 1 episode that lasted for just 5 minutes. The intensity was same. And the last day, he never had any episodes of headache at all.
So dear friends, what Sucharita is showing is something of a substance use headache disorder, which was totally unrecognized by myself and maybe all my colleagues not only in India, maybe across the world, because we have totally and thoroughly missed this entire concept of substance use headache disorder. And I have already around 6 cases. This is the 7th or 8th case of substance use induced cluster headache. And this is a classical pattern you see with substance use headaches. So they improve by 3rd day. So most of the duration, intensity, and don't do anything when you suspect a substance use headache disorder, otherwise you can't diagnose it. You just stop the stimulants, which are mainly containing the essential oils of camphor and eucalyptus, be it the toothpaste or the balms and oils or tablets or inhalers you use, you stop it. Just give a headache diary to prove your point. And you can see that the headache just comes down in intensity. And by 3rd day, you know that you are in the track. And this patient, we have not done anything. We just send him home. And I have not written anything. The residents were managing. I just told don't do anything other than stopping the medicine, and it causes. So this is a classical substance use related cluster headache. And I will tell you the science behind it, because people don't believe. Even I think Sucharita didn't believe when I told her what you're doing. I told you just do that and just take a headache diary and follow up. And they were all very surprised to see what happened. So I'll explain the science behind it. Hilly, can you just share my slides?
Sure, sir.
And just give me the control so that I can move.
Sucharita, you have to stop sharing.
Yes, sir. Yes, sir.
Yes, sir.
So, ma'am, you can.
Dear friends, this is a summary of a great journey we started in 2014, and we are just still going on it and just seeing the depth and the breadth of what we have come across. And I urge all of you to keep an open mind when I give presentation, and please ask your patience and don't think too much, because otherwise you will miss the point. So this is something called substance use related headache disorders, and especially what I'll be touching upon in essential oil. And Dr. Sudhir Shah told that if Dr. Thomas is there, something with aroma will come up, and that is what it is. And so I'll take this opportunity to enlighten you a little bit on the latest what we are on. So the slide sharing option is with me. Can I move?
So you need to accept.
No, I didn't get anything to accept. Can you just send the link?
Sir, this is you moving the mouse, I guess.
Okay, I'm only moving the mouse. So
Yeah, I'll just mute myself, sir. Just a
Yeah,
minute.
1 minute. I'm moving? I don't think. 1 second. Yeah, I think I'm moving. Yes. So the story started long back in 2014, when we had eucalyptus oil inhalation and seizures in around 10 patients in Bangalore. And then we reported, so we were aware that eucalyptus oil is a proconvulsant. And then we had seen literature on people getting seizures with Vicks vapor rub and all those things. And we knew that Vicks vapor rub was eucalyptus and camphor. And most of your over-the-counter balms are nothing but camphor and eucalyptus, be it Amardanjan, Jandu balm, or whatever you take. And then we had patients with status epilepticus due to essential oils, drinking eucalyptus, applying and getting various types of status epilepticus. And many of the seizures we came to know that are provoked or induced by these essential oils. People used to put Amardanjan in the nose and sleep and get seizures in the night. People used to put eucalyptus in their bed and sleep and get seizures in the night. Mothers due to bathe their children with eucalyptus oil and put Vicks daily to prevent cold and used to get seizures which were uncontrolled. And then we found that when we remove all these substances, the seizures disappeared and stopped most of the medications, or at least the number of medications could be reduced. And the entire concept of essential oil related seizures we had published in Epilepsy Research in 2021. And then the journey continued because, as we know, the epilepsy and the seizures and migraines are same. And then we had published the essential oil, the balms induced essential oil related medication overuse, headaches, and migraine. And friends, these are the 11 plants of essential oils which are powerful convulsants: camphor, eucalyptus, rosemary, fennel, hyssop, pennyroyal, sage, savin, tansy, thuja, turpentine, and wormwood. And these are powerful convulsants, and there are many reports on these causing convulsions. And many of the things our patients use have these oils, maybe toothpaste, maybe the soaps, maybe the balms, and anything you say, you might have essential oils. So this is just 2 years back. We had, I had a patient of cluster headache referred by one of my friend, Dr. Mahindra Javali from Ramaya. This patient had cluster headache for almost 10 years. And usual cluster periods were 3 times in a month, lasting 3 to 4 weeks. And they used to treat with small doses of steroids and verapamil, and wonderfully used to respond. So the last 1 year before he referred to me, the cluster was continuous daily. And when he met me, when he was referred to me, he was on topiramate 100 milligram and verapamil around 80 milligram 3 times. And the patient was not responding to the treatment. So MRI and the usual things were negative, and I was checking whether he was applying any balms and oils. He told I was not applying the balms and oils. Then I just asked, what's your toothpaste? And he told, I think he was on Colgate Veda Shakti or one of those toothpaste which contained camphor. Then I just requested him, just stop it and come and meet me after 2 weeks, and gave a diary, and they didn't change any management. And to my surprise, his headache melted away by 5th day, and by 10th day, his all headache went off. And today it is almost 3 years follow-up, and I keep in touch with WhatsApp to the patient and never had any clusters after that. So when I presented this in many of the meetings, they told, Thomas, you are dreaming too much and you are imagining too much, and this is a spontaneous recovery. So then I was waiting for my next patient. And then after a few months, a sister in our hospital came with a cluster type headache lasting for 3 attacks per day, 3 to 5 attacks per day lasting 20 to 30 minutes, and watering of the eyes and things like that. She had headache for 3 weeks, and she was using, I think, again, Dabur Red or one of those toothpaste, which were containing camphor. And then I asked her to stop, and to my surprise, her headache disappeared in 3rd day. So then I waited for 2-3 months, and I requested the sister to re-challenge with the same toothpaste. And exactly 2 months after using the toothpaste, she got the cluster attack again. Then I stopped it and it disappeared. So this was the first 2 cases of essential oil related cluster headache. And then I was able to successfully publish it in BMJ case reports as the first case reports of essential oils and the cluster headache insight from 2 cases. So now I have almost 6 or 7 patients. These are the 5 patients which we presented in American Headache Society in Denver recently. These are all various patients, and we had 2 males and 3 females. And the cluster duration was the first case I was describing, 9 years of cluster and 1 year worsening. The sister I told was 3 weeks. And then we had another staff in the billing session who came with cluster of 2 weeks. And she was on a base which was containing camphor and clove for 6 months. And she was surprised that I asked the toothpaste. She was asking, sir, why are you asking toothpaste? Then I asked her to stop the toothpaste. And again, she was asking, sir, give me some medicines. Then I will just wait for just 2-3 days. I'm here. We'll give all the medicines. We know what all medicines to give. And we begged her not to take anything. And by 3rd day, her headaches also went off. Then we had other patients, and most of them were using this paste for 3 months to few years. and then they stopped, and then the cluster improved. And then these were the toothpaste. I think the first patient was on Patanjali Dantakanti, the second was on Colgate Vedashakti, the sister. One patient was on Dabur Red, other was on, again, some Patanjali with other stuff he was using. These were the toothpaste in various patients. So now this we presented in the American Headache Society, recent as a poster, the substance use related cluster headache, a case series. And then if you just go to the contents of most of these toothpaste, you can see camphor there. Camphor is not supposed to be taken by mouth because it's a neurotoxin. Children who swallow camphor can have seizures, they can have coma, they can die. So taking camphor daily, slowly over time, because the amount is small and you are just taking a sublingually or around the perioral or buccally, you are taking daily, the amount is small. So the toxicity happens over a few months. It doesn't happen immediately. So sometimes we have seen it happens by somewhere around 2 months to 3 months. And then the toxicity happens. And many of the Colgates have eucalyptus also. Sometimes they don't write the term camphor. You have to check carefully the various things. And here you can see Salvia officinalis. And there are 40 plants which contain camphor, and it is one of them which contains the camphor. So you can have, you can test in the, the Google, so you can get the contents of the toothpaste, and many of them tell, and they proudly announce that it contains camphor without knowing what are the side effects of camphor. And then sometimes you see this mentha spicata, which contains polygon, which is a proconvulsant. And sometimes you get something called Salvadora persica, which is a plant which contains essential oils of thujon, which is a GABA receptor antagonist. And also it also contains cineol, which is eucalyptol. And then it also contains camphor. We have 3 proconvulsant essential oils in this toothpaste. And then like the Salvadora persica, you have to carefully search for the contents. So the essential oils contained in Salvadora persica, if you say there is wonderful literature on both of all these botanical plants, and you can see that there are thujons, which are camphor, cineol, and various essential oils are present in this toothpaste. So now if you see, I was discussing this concept to Professor Godsby once, and he sent to me a paper that day on headache tree. And headache tree is a tree called California bay leaf. Many of us put in for when you take food, you may put this California bay leaf for the aroma. And an inhalation of it vapors can cause severe headache crisis. And there was a case report on the pleasant natural scent with unpleasant effects, the cluster headache-like attacks triggered by Umbelluria californica. So this is a case of a man who had cluster headache when he was young, and he inhales this Umbelluria californica and gets headache attacks, and he visits his doctor. So then the doctor is surprised, and he's not leaving that patient. So what he does is that he takes it up, and then around 11 centers in the world sit on one patient who had a cluster headache due to the California bay leaf, and they find monoterpene, which is called umbellulone. And they find that the umbellulone in a rat model activates the transient receptor potential channels ankyrin 1, and it activates the trigeminal system, and it causes CGRP release. So they find that, and you know that in patients with migraine and cluster headache, the blood of the people shows a CGRP level, which usually double than the normal people. So this stimulation of transient receptor potential ankyrin 1 in a subset of peptidergic and nociceptive neurons results in activation of the trigeminal system and results in calcitonin-related peptides in rodent trigeminal nerve terminals. And most probably that is a mechanism of cluster headache caused by umbellulone in California bay leaf. And the calcium, as I've just told, the calcium gene-related levels are increased in cranial circulation during patients with migraine and cluster attacks. And there are many stimulants of TRPA1 channels, while alcohol is a TRPV1 stimulant, the TRPA1 by umbellulone, and it causes the CGRP release and vasodilatation. Camphor, cineol, thujon, and phenol, which are present in most of these oils and balms and toothpaste, are also monoterpene ketones like umbellulone, and they can activate the TRP channels. And the camphor activates TRP vanilloid 1 and cineol TRP melastatin, and thujon TRP vanilloid V1 and V3, and phenol TRP ankyrin. And even other TRPA1 agonists like cigarette smoke, which is highly associated with cluster headache, and you can also have various other chemicals which are TRP1 antagonists. And as we told, camphor and thujon are TRPV1, and alcohol and wasabi also is a TRPV1 antagonist. So the TRP channels are abundant in the posterior hypothalamus, which is important in cluster, and trigeminal nuclealis caudalis and trigeminal ganglion neurons, which are areas involved in cluster and migraine pathogenesis. And this may be the reason that there is a lot of substances. TRP channels are non-specific microthermistors, which are present in the mouth and also in the various trigeminal ganglia and the hypothalamus. So that's why when you take a substance like whatever, we feel hot, warmth, and spicy and happy at that time. But when it gets absorbed and when it reaches your brain and touches the trigeminal ganglion neurons, which are peptidergic and nociceptive, or reaches the posterior hypothalamus and touches, you get headaches, and then you may get other problems. And various studies are there, and TRPA1 and TRP1 are seen in significant proportion of trigeminal ganglion neurons. TRPA1 is also expressed in the pacemaker neurons of hypothalamus, and because the pacemaker neurons are important in cluster, because you know that a circadian rhythm is followed in the cluster. So the probable mechanism of essential oil related cluster headache is that essential oils like camphor, eucalyptus, or thujon like umbilolone may stimulate the TRP channels in the pacemaker and nociceptive peptidergic neurons of the hypothalamus and trigeminal systems, leading to cluster attacks. So why only a few people develop cluster attack and others do not is a big question. But with more understanding, I'm seeing anxiety disorders, palpitations, peripheral nerve hyperexcitability syndromes, functional vertigos, where we thought it is psychogenic. And then you think it is psychogenic. There is nothing. Patients still, I am not anxious, no depressed. I feel I have little imbalance. So all types of migraines, seizures, anxiety disorders are caused by these contents which are there in this toothpaste. And because the toothpaste is one toxin, I think, which we take daily, and then meticulously sometimes twice a day, and then especially the herbal ones. And I think a lot of neuropsychiatric disorders, the underpinning is this proconvulsive essential oils. And more and more you realize this, you start stopping this, and most of these disorders works like channelopathies. And once you stop, you see the effect by third day, maximum by fifth day or first week, and by 2 weeks, they'll be fine. So most of these disorders, when you have a doubt, especially the hyperexcitable neuronal disorders like migraine, cluster, seizures, anxiety, and palpitations, and peripheral nerve hyperexcitability syndromes, and cramps, and functional vertigos, please think of whenever you know your MRIs are usually normal in most of these patients, and you don't have a better explanation, check their toothpaste always, and their balms and oils. And toothpaste don't miss. And now my interview starts with the toothpaste, because I will also forget at the end of the day. If I don't ask, I miss the diagnosis. Just recently, my friend's son, who was a medical student, was studying with us, an intern came and told me, sir, I'm having an imbalance. I examined him, no nystagmus, no rhombus sign, nothing. Everything was perfect. I asked his toothpaste. He told, I'm on Meswak for the last 2 years or 3 years. I told, please check and stop it and come back. And now exactly 1 week over, he messaged me, sir, I'm better. I've already improved, and I didn't do anything for him. So these are most of my OPDs, 50% is just stopping the toothpaste, and migraine now, rarely I write medicines. So essential oil related headaches and brain disorders are common and under-recognized. If you don't believe, if you don't ask, and you don't give the diary, and you keep their phone number, and please call them and ask what it is, you won't see these miracles happening, because once they are better, they won't come back to your busy OPD. So when you do these type of things, take their phone number, keep them as a WhatsApp contact, and please call them and ask. Otherwise, you'll not see these miracles what we are seeing now. So in short, checking the contents of the products in patients with hyperexcitable neuronal disorders is of paramount importance, because nothing is written in the textbook. No American or no British has spoken about it. So don't neglect it. Please keep it in your mind, and please ask your patients. And just 2 days back, we published the first time report of substance use related cluster headache in headache. In June 22nd, it was accepted, and it just came first time description of substance use cluster headache, a case series. I think we will have more cases. And please message me personally and tell me if you see any patients, so we can strengthen our hypothesis and the clinical findings, what we are seeing. And be careful with the leaves. Don't get hooked by the advertisement showing natural and safe. Cocaine comes from plants, poppy leaves come from plants, tobacco comes from leaves, camphor comes from leaves, cannabis comes from leaves, eucalyptus comes from leaves. So natural things can be dangerous at times. Be careful. Thank you.
Fantastic, just fantastic. Dr. Lakshmi?
Yes, sir.
Yeah.
Really a wonderful show. As usual, Thomas, you have stolen the show. Excellent. And I'm sure it's a eye-opener for many of the participants who are here. And as you rightly said, it's very difficult to convince people about what you said. And I know your journey. I've been watching this, and then I told you, in fact, I also shared that I also find so many things very common in my practice. And I have started, as you said, I've started stopping all this, what they claim to be so innocuous things. They are not as innocuous as they claim to. So wonderful presentation. And the plants have got a lot of interesting facts. There is one plant in the Western Ghats which blossoms only when a female embraces the tree. You can check that, and that is, in fact, that is the place where Lord Kartik, the god Kartik, had declared his love. Asked one of the, in the old stories, it says that the lady, he asked her to embrace, and next day the entire tree blossomed. And I thought it looked foolish, and then I looked into the science behind it. There are trees which get blossoms only by a touch of a human female. I was surprised. They are existing. And I think, the plants is a wonderful area which is untouched. And Matthew, wish you a lot of success in taking this story globally and bring credit to. Thank you.
And one more thing I will add. I didn't show the full mechanisms how camphor and eucalyptus has. It blocks the potassium channels. So usually your drugs like gabapentin and pregabalin, or you take phenytoin, or most of our drugs for all the hyperexcitable disorders, you take migraine, valproate, topiramate, or epilepsy, they're just sodium and calcium channel blockers. So the conventional action potential curve, you block the sodium and calcium channels, the action potential amplitude will come down. But if you block the potassium channels, the action potential amplitude will go up because it is a repolarization. So we have delphamidine, famidine, and 3,4-aminopyridine. They are potassium channel blockers, and their side effects is seizures. So potassium channel blockers are known to cause seizures. And both this camphor and eucalyptus have shown in snail neurons that they are blockers of potassium. So this have two implications. One, they themselves can be pro-stimulant and pro-convulsive and pro for hyperexcitable. And also that it counteracts your medicines. So you get pharmacoresistance. If you're a radiculopathy patient, you are giving pregabalin, and he's putting Vicks and Amarthajan, your pregabalin won't work at 75 milligram twice a day. You have to give 150 milligram twice a day. So it is important to tell them not to take anything else. And it includes Ayurvedic and homeopathic medicine. Most of the Ayurvedic medicines have camphor or one of the sorts. And then most of the homeopathic medicines have thuja and things like that. It not only have intrinsic pro-convulsive effects, it can counter the action of your medicine. So your double dose of medicines will have to be given. And third thing, they're all inducers of hepatic enzymes, because there are so many ingredients in this. One drug of an Ayurvedic medicine will have 11 plants, 30 plants, and 30 plants will have 100 ingredients. So this is foolishness to give to patients because you don't know where it will affect. And this will induce the hepatic enzymes and which will take out your medicines. So not only you should not tell and you do whatever you want, you go to, it is not correct. It is scientifically true to stop everything, give minimum poisons to the medicines. At least we are very pure toxins. So when you have things which you don't know, we are all interactions and stuff like that. So it is time to say to people not to take other things which are unscientific. Anything labeled, please don't take. Unless you are not able to check in the Google, please don't take anything. They believe everything. They will come with violet color fluid, a powder, which have no labels. So it's a time people should open up their mind. Don't go with unscientific thoughts and take everything given. And so we have no idea what they are taking.
Dr. Thomas, I have one funny idea that when you really practice this kind of removal of all essential oils and including, camphor and eucalyptus and other essential oils and including these Vicks and other menthol things, I think the shop of the headache colleagues would be shut down because most of them.
That's what's happening. So rarely we write medicines now. We are giving headache diary and just copying the toothpaste. And 90% said, don't believe me, I don't check with them. My sisters call them and they are surprised. They will tell, sir, 90% people have improved, sir. I told, okay, thank God. They are fine. We are happy and it is there. So it is a remarkable journey. And when this cluster headache patient admitted, so DM resident Sucharita was telling, sir, what you're telling? I told you, just stop and give the diary and see. And they were all surprised to see that the headache disappeared by third and fourth day, and they discharged the patient. And
my hearty congratulations to the entire team from Bangalore. And I'm, in fact, I should say I'm jealous of your team because the sections, everything is of high standard. Thank you so much, Professor Matthew. And I hand over the mic to Professor Sudhir Shah for conclusion.
Oh, Dr. Lakshmi, I thought your words are very precious. You could conclude the thing. Anyway, all of us would agree that this was really one of the wonderful sessions, and all three cases were a great learning exercise for us. And the fascinating was this, of course, essential oils, aromas, and headache. And in fact, today, Dr. Thomas did not touch much upon epilepsy, but that is also another wonderful journey that he has. And I had a fortune of calling him about 5 years back at Ahmedabad, listening first and all these things. And he went on and on for an hour or so. And all the neurologists in the crowd, they were all flabbergasted. My God, there was a complete pin drop silence. And I think this is really a very innovative thing that he has done, a great service to the society. And I really, once again, congratulate him, and on behalf of myself, Dr. Lakshmi, and the team in TAS. Of course, on behalf of all the residents and those who have attended the session. And I must also thank and compliment Professor Raghunandan and both the speakers, the student as well as the associate professor. I think we will have archive of this talk. We can ask Dr. Daly or Mr. Arun Chadda, those who want to listen this again carefully. And we await sometime next year for his series on epilepsy. Thank you for unflinching support, all the delegates. Every time we have been very kind to be there till the end. And next session will be the last Friday of August month at 8 p.m. We await. Thank you very much. Good day.
Thank you, Sudhir sir and Lakshmi sir, and all my team, Raghu and Sucharita and Akshada, for their wonderful contributions and presentations. And thank you. I think somebody has raised a hand from the participant. I don't know whether any question is from there or I don't.
Yeah.
Oh. Thank you, sir.
Sucharita and Akshata, I forgot the name, but I just said.
Sir. Thank you.
Yeah.
Thank you. Thank you.
So over to Mr. Arun Chadda.
Thank you, sir. And today is a really great day that we are at the end of 25th session of Secret of Neurology web series, which is the longest ever web series till date. I, Arun Chadda, Associate Vice President, on behalf of the Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 25 months, and it's audience like you that make the presentation awesome. Thank you very much for your unwavering attention throughout this presentation. And this presentation is very special because the time frame which was given, that was very less. It was just less than 1 week time we have. That time was there with the St. John people. Thanks to Dr. Thomas Matthew and their team. And I would like to thank our Honorable Course Director, Dr. Sudhir Shah and Lakshmi Narasimhan sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And most of the time, we are getting a phone calls for the next episode, what is the topic and how it will go on. We are thankful to our young neurologist, Dr. Sucharita, for presenting the excellent and unique cases. Further to this, I would like to thank Dr. Akshita ma'am for presenting the differential case studies. And further to this, I would like to thank Professor Raghunandan sir for case analysis, and thanks to Dr. Thomas Matthews sir, Professor and head of the Department of St. John Medical College, for providing the important learning and the proceeding of the unique cases and experts for such a unique case with fabulous presentation and the uses of eucalyptus also. And the entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence, and it's being a pleasure being with all of you today. You all and will be there, and I wish you all a very good night now in this month, and we will meet again on 26th August with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you, sir. Thank you very much.
Thank you all. Good night. Thank you all. Bye.
Thank you.
Thank you.
Thank
Thank you
you.
all. Thank you, sir. Thank you, ma'am.
Sir, you are on mute.